From Warts to Warnings, Unmasking the Invisible Viral Architect. Welcome to the HPV Masterclass. Today, we dive into one of the most mysterious, misunderstood, and mischievous viruses in sexual health, human papillomavirus, or HPV. It's stealthy, it's common, and while most of the time it's harmless, it can leave behind serious consequences if left unchecked. Let's peel back the layers and get to know HPV from the inside out. What is HPV really? HPV is a small DNA virus that doesn't look like much, but don't be fooled. It's the mastermind behind genital warts, precancerous changes, and even cancers of the cervix, anus, throat, and more. There are over 150 types, but two big categories matter. Low-risk types, like HPV 6 and 11, cause genital warts. High-risk types, like HPV 16 and 18, cause cancer. HPV doesn't spread through blood. It spreads through skin-to-skin contact, friction, not fluids. That means condoms reduce the risk, but don't eliminate it. How you catch it? Invisible, but incredibly common. The vast majority of sexually active people will get HPV at some point. Most never know they have it. The immune system quietly clears it within 2 years. But sometimes, it lingers, and when it does, that's when it may start nudging cells toward abnormal growth or warts. Risk factors that turn up the volume: more sexual partners, younger age at first sex, HIV or other immune suppression, smoking, co-infection with other STIs like herpes or chlamydia. The virus at work, how it hijacks the host. HPV is like a hacker that sneaks into a computer and rewrites the code. It binds to tiny breaks in skin or mucosa, slips into basal epithelial cells, then uses the host cell machinery to replicate low-risk types, stay superficial, causing warts. High-risk types go deeper into the cell's nucleus, where they release two rogue proteins. E6 degrades P53, your cell's self-destruct button. E7 disables RB, the tumor suppressor that keeps cell division in check. The result? Uncontrolled cell growth, mutations, and eventually cancer. What it looks like? The clinical faces of HPV. Anogenital warts, aka Condylomata acuminata. Warts come in many styles: cauliflower-like growths, smooth and flat papules, keratotic hard bumps. They're usually painless but can cause itching, discomfort, or bleeding. And emotionally, they can carry huge stigma, even though they're non-cancerous and manageable. Precancerous lesions and cancers. HPV can cause silent changes long before symptoms appear. This includes cervical intraepithelial neoplasia, anal intraepithelial neoplasia, AIN, oropharyngeal squamous cell carcinoma. Often, the only way we know HPV is present is through screening, which brings us to how we detect it, screening and diagnosis. Warts, diagnosed clinically, biopsy if lesions are persistent, unusual, or in immunocompromised patients. Cervical screening, pap smear checks for abnormal cells. HPV test detects high-risk types. General approach? Start PAP at age 21, between 30 to 65, PAP plus HPV test every 5 years, or PAP alone every 3. Anal screening? Not universal, but essential for high-risk groups. MSM, people with HIV, anyone with a history of cervical or vulvar dysplasia. Tools include anal cytology, high-resolution endoscopy, treatment. Target the lesions, not the virus. Here's the truth bomb. There's no cure for HPV itself, only for the lesions it causes. For warts, patient-applied treatments: imiquimod, immune booster, podophylax, antimitotic gel, sinocatechins, green tea extract with antiviral properties. Provider-applied options: cryotherapy, freeze them off, TCA-BCA chemical burn, surgical excision, or electrosurgery. Recurrence is common, but not a sign of treatment failure. Think of it like trimming weeds. You control the overgrowth, but the root virus may still be there. Pregnant? Avoid podophyllin and imiquimod. Go for cryotherapy or surgical removal if necessary. HPV in immunocompromised patients. For those with HIV or other immune issues, lesions tend to be larger, harder to treat, and more likely to recur. Persistent warts equals always consider biopsy, suppressed immunity, less HPV clearance, higher risk of malignancy. Regular screening and early detection are critical here. Prevention, vaccination, safer sex. HPV vaccine, 9-valent, This vaccine is a game changer, and it's not just for girls. It protects against HPV 6 and genital warts, HPV 16, 18, 31, 33, 45, 52, 58, cancers. Vaccination schedule: ages 9, 2 doses, ages 15 to 45, 3 doses. Even if you've already been exposed, it still offers partial protection. Bonus: it helps reduce HPV circulation in the population, herd protection. Behavioral prevention: condoms help, but remember, HPV is skin to skin. Limit sexual partners, encourage regular screening and follow-up. Counseling: combating confusion and stigma. Patients may be scared, embarrassed, confused. Here's how to empower them. HPV is extremely common. You didn't do anything wrong. Most infections clear on their own. There's no need to test or treat your partner, just get vaccinated. You can still have a healthy, normal sex life. Vaccination protects you and future partners. Bottom line, what every clinician should know: HPV is the most common STI in the world. Most infections are asymptomatic and transient. High-risk types can lead to cancer, but we can prevent and detect early. The vaccine is safe, effective, and underutilized. Treat warts, not the virus. Educate without judgment. Empower with facts, not fear. Congratulations, you just completed the HPV Masterclass. From microscopic capsids to massive public health wins, you're now ready to test, treat, vaccinate, and talk about HPV with confidence.